Thank you very much indeed, Mr. Chairman. Ladies and gentlemen, it's a real pleasure to be here today and have the opportunity to discuss the issue of chaperones and andrology, and not just andrology, but urology as a whole, really. It's an interesting area, but I can't pretend it's particularly highbrow. It's not prostate cancer, this. It's not particularly highbrow. It's extremely unlikely that I'm going to say anything particularly controversial. I can promise you that I certainly did not search through 1 million papers before I came here today. There are no raging controversies. It's unlikely that one of you is going to want to come out of your chair up here and pull me down off this stage. Never speak too early. It might happen. I can see a few faces that might want to, but it's pretty unlikely. And I can absolutely assure you that during the duration of this talk, there will be no mention of MRI. Not before, not during, not after. So why bother? Why bother taking up a session talking about the issue of chaperones? This is why. I think you'll all agree this is pretty much the stuff nightmares are made of. The gentleman to the left of your picture is a consultant gynecologist. I have put this up with his permission. I spoke to him only a few weeks ago. His name is Angus Thompson. He works in our trust, the trust that I'm currently training in. The lady that you see in the picture there is one of his old patients. This is an incident that took place about 4 years ago. Essentially, this lady came to see Mr. Thompson privately, and following a fairly routine gynecological complaint, he took a history, examined the patient, which included an abdominal examination and also a speculum examination. This was all done in the presence of a chaperone. He actually dealt with this case rather interestingly. He saw the patient and sent her away for some investigations, and upon her second visit decided that due to her slightly strange affect and also what he described as inappropriate behaviour, he didn't really want to see her again. So he wrote a letter to the patient and also to the medical director informing him that she had behaved somewhat inappropriately and he didn't wish to see her again. About 9 months later, he received a letter, and the letter stated from the patient that she felt she'd been sexually assaulted by him. He, according to her, had given her a leg buckling orgasm. He was quite surprised by this, I think rightly so, and given the fact that there was a chaperone there, this wasn't going to pose too much of a problem. It's a lot of paperwork, it's distressing, but he could quite easily prove that this was not the case, and clearly the patient was wrong. The inevitable happened. The private hospital investigated the case at length, and in doing so quickly came to the conclusion that Mr. Thompson had done nothing wrong. It was then investigated by the trust, the Worcestershire Acute Trust, who also came to the same conclusion. They pored over the notes, and finally, the one that we all worry about, the GMC review took place, and they also pored over the notes, looked at all the available evidence, including the evidence that came from the chaperone, and decided there was really no case to answer. Good, all done, dusted, and clearly we don't need to do much else with this. Not quite. It's not quite how it works. And it was interesting, whilst I was looking through this material, that I found it is fairly easy for a patient to raise a civil case against a doctor. In fact, all it really takes is a claim form, £500 to £1,000, and to find somebody that's willing to represent you. The judge in this case, despite the GMC, the private hospital, and the trust dismissing the case, felt that this was an important issue. It needed to be addressed carefully, and therefore upheld her right to have a civil hearing. Claimants don't actually need to establish the validity of their allegation in a robust manner prior to having a hearing. And very interestingly, the claimant maintains her anonymity, whilst of course the surgeon, Mr. Thompson in this case, does not. And the inevitable follows, the sensationalist headlines. So we've gone from a case which really, in a way, had no legs, to a case which is now across the media. There are headlines such as "Gynecologist gave me 2 orgasms in 2 minutes." She's already claimed that he gave her a leg buckling orgasm, and there's also the issue of abuse. In the end, within a week of this case being heard, the claimant decided to drop the allegation. Why? Because actually several other doctors came out of the woodwork and gave evidence to the effect that she had done this previously. There was previous history of such claims. She took the bill for the case, and all in all, from beginning to end, this was a 3-year ordeal. This was an extract from the newspaper, the local newspaper. Standing on the steps of Worcester County Court with his GP wife, Lucy, Mr. Thompson collapsed in tears as he described the relief of being able to return to work with his professional reputation intact. And there is some doubt over that, because once this sort of thing gets in the media, it's a hard and long road back to where you were before any of this happened. He claimed a 3-year ordeal, ending with a week in court, had been unspeakably stressful. And speaking to him only a couple of weeks on the phone, that's probably an understatement. I think we're equally vulnerable, actually. We regularly perform examinations of an intimate nature. We have conversations of an intimate nature. We live in a culture where complaints are rising. I know Mr. Summerton's going to expand on that further. 10% or so of the complaints that we now receive are related to the attitude of staff. There's plenty of guidance. There is very little excuse for being caught out. The GMC have got very clear guidances on what's expected of each and every one of us. We should all be making a chaperone available to all of our patients all the time. Ideally, apparently, this should take place at the time of booking. I think that's almost unheard of. I certainly haven't seen it. If the patient decides they do not want to chaperone, you must document in the notes that the offer was made in the first place. Chaperone training. How many of your chaperones are trained adequately to do the role? They must understand what's meant by the term. They should understand what is meant by an intimate examination. And very importantly, they should also understand what the rights of the doctor and the patient are. In doing so, and perhaps most importantly, they should really understand what the policy and the mechanisms within your trust are to raise the matter higher up. So I think around 12 months ago now, we concluded a brief survey. We surveyed all UK urologists through BAUS membership. That included trainees, consultants, trust-grade doctors, and it was a very simple 12-question SurveyMonkey questionnaire. We had a 26% response rate, and encouragingly, 261 consultants replied. And we found some interesting things. Almost 40% of those that replied were not aware of any GMC guidance on the use of chaperones. 80% or so felt that a chaperone was necessary during intimate examination. It does beg the question what the other fifth felt. Patients of the same gender, really interesting area. I think it's reasonable to say that certainly during my training so far, you do have a more lax attitude for patients of the same gender, and I'll come on to why that might be later on, but we are all human, and inevitably we make presumptions. Documentation, this is a really interesting one, because in Angus Thompson's case, the documentation and the chaperone testimony really did save him. 40% of urologists document the use of a chaperone in clinical notes. Actually, I was surprised by that, pleasantly surprised. I thought that was higher than what we might hear of. So what have we learned? Well, we've learned that there's a tremendous variation in practice amongst urologists in the UK. I suspect that's representative of urologists everywhere. There's an "it won't happen to me" attitude, or one can certainly assume that that's the attitude, because the results can't be explained in any other way, really. We make presumptions. We make presumptions about people's sexual orientation. Oh, it's a bloke, it's okay, I'm a bloke, it will be fine. We make presumptions about their age and how they perceive their examination. And we also make presumptions about their vulnerability, whether that be cultural or again, as I say, age, or what they actually understand about why they're there in the first place. Overall, I don't think as urologists we comply particularly well. I spoke to David Eddington. He's a very well-established QC, criminal QC in London, been in practice for many, many years, has looked after many high-profile cases. And his quote was, anything outside the GMC guidance as a minimum, would be courting trouble. This brings us to what David describes as the 6 guiding principles. Do not assume it will not happen to you. It may very well happen to you. Gone are the days where professionals were untouchable and such allegations did not come your way. And always remember that a small minority of professionals will deviate from the rules, will act inappropriately. So actually it's quite important that patients have a way of making claims, of things being escalated appropriately. Read the guidance, okay? And not just read the guidance, but I think perhaps there's a role during training to try and establish how trainees establish that, interpret that guidance. Because reading guidance is not quite enough. We all do induction, death by induction. Whenever we join a new trust, the trainees will be aware of that. You read it, but that doesn't really mean you know what to do when the fire happens and all the doors are shut and the lifts have stopped working. But you did the induction, so therefore you should do. It doesn't work that way. The third principle is the blush test, okay? If tomorrow you arrived in your office and such a complaint arrived on your desk, could you really go back and say, I wouldn't do anything differently? Would you do anything differently at all? And if you would, what would it be? And how might that change what you do next time? And that's a very important question to ask yourself. Think about it before, not after it happens. Can you rebut the allegation? And you can say, well, yes, of course I can. I've been in practice for X number of years. It's never happened to me before, and my patients think I'm fabulous. Of course I can rebut it. Well, can you, though? Again, this is something that you need to think about before, not after the allegation's made. What sort of evidence can you provide? Did you have a chaperone? Is their name in the notes? Does your chaperone actually know they were there to chaperone? Or do they think that they were in clinic for some other reason? You'd be amazed. You should be on guard. You should. And there's that old thing about intuition. When it just doesn't quite feel right, the patient walks through the door, you think it's all a bit strange, they're behaving a bit oddly, trust your intuition. Get someone else in clinic with you, get a chaperone in, and make sure that they understand why they're there. And I think the 6th is perhaps the most important. The best way to enforce ethical standards is peer group pressure, okay? So there are several examples of this, but we can set a number of rules, we can tell people to do it, but unless we change the underlying culture that we live in, things won't change. And we will continue to take this as something not particularly important, but something that we should vaguely be aware of. It's irritating. You stand in clinic sometimes, you stand at the door, you're waiting for a chaperone, one doesn't arrive for about 5 minutes, you're running late, the patients are complaining, and you think, oh, you know, fine, it's just a quick examination, I'll get on with it. There is no doubt, speaking to Angus Thompson the other week, that the irritation and the disruption that that might cost is a drop in the ocean compared to the potential implications of not complying with the rules. If any sort of allegation is actually proved, any kind of sexual impropriety, it could result in the end of your career, and in worst case scenario, in a criminal court, it could result in a substantial and immediate prison sentence. I'll end with this. When life gets all a bit too much, it does sometimes as a trainee, doesn't it? And you drive to work in the morning. I like to listen to this song. You might remember this song, Baz Luhrmann, from a few years ago. And I particularly like this part of the song. Don't worry about the future, or know that worrying is as effective as trying to solve an algebra equation by chewing bubblegum. The real troubles in your life are the things that never crossed your worried mind, the kind that blindside you at 4 p.m. on some idle Sunday. I suggest that we make this something that crosses our mind fairly regularly to try and avoid it becoming a real trouble on our mind on an idle Tuesday. Thank you.